Hello, everyone, and welcome to today's webinar, Avoiding Common Pitfalls in Laboratory Testing for Providers and Laboratorians. I am Sabrina Lemus of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Radiometer. To learn more, visit radiometer.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. This webinar is educational and thus offers free continuing education credits. Please click on the continuing education window at the bottom of your screen to obtain your credits. I'd now like to welcome our speaker, Joe El-Khoury, Associate Professor of Laboratory Medicine at Yale School of Medicine. Joe, welcome. You may now begin your presentation.
Thank you, Sabrina. Good morning, good afternoon, and good evening to all of you, wherever you may be in the world. It is my pleasure to be talking to you today about avoiding common pitfalls in laboratory testing for providers and laboratorians. The goal from designing this educational session was for me to get laboratorians and providers together to address these issues that can arise when ordering or performing testing that require both of us really to work together to address them. And before we begin the session, I'd like to disclose that I am receiving an honorarium from LabRoots for giving this talk. I'm also a consultant for Siemens Healthineers and AACC. I'm on the board of directors, but I will not be discussing any of their products. And also, as already mentioned, this webinar is sponsored by Radiometer. I would also like to mention that I am available on YouTube as well. So if you like the educational content you see here, you can access them on YouTube. I'm creating videos. I only have 3 so far, but I'm working up to make more of these videos that focus on best laboratory medicine practice. And for today's talk specifically, we're going to be focusing again on common pitfalls in laboratory testing, specifically looking at clinical chemistry testing, which is my area of specialty, and then identifying some solutions that we can implement to reduce the risk of these happening. And this will require, again, cooperation from providers and laboratory professionals. But before we begin, I'd like to get a sense of, the audience, who you are. Are you a healthcare provider who orders laboratory tests frequently? Are you a laboratorian who's involved in providing these services? Or are you a student simply interested in learning about this topic? So please start by answering this question by clicking on the poll so I can get a sense of who the audience is. Seeing a lot of results coming in, so we'll give this another 20 seconds. All right, and to keep this moving, I noticed the majority are laboratory professionals with a few healthcare providers and a few students, so I'm going to push the results so you can all see them and we'll keep moving forward. So I have 6 cases to present to you today, and I've saved the best for last, which is about hemolysis. So that is a pretty common one that we'll be addressing at the end of the session, but beginning with other common conditions that we see, one of the more common ones is unexplained hyperkalemia, commonly referred to as pseudo-hyperkalemia when it's a false elevation in results. So this one we see on both the provider side or the laboratory side, and basically it occurs like this, where a patient shows up. In this case, it's a 61-year-old man admitted to emergency medicine for an increased potassium concentration of 6.3. The reference interval for that lab is 3.5 to 5, and that was discovered at annual checkup. So physical examination was not consistent with it. It did not reveal any symptoms that was associated with hyperkalemia. And when the patient was brought back into the ED and tested, they had a new result, which was drawn in the hospital, that was 3.7. So I ask, what could be causing this, and how often do you see it in your laboratory or clinic? So what's also puzzling here is that specifically unique for this patient is that this is the 3rd time this happens to them, When they go to the ED, because they had a test that was performed in an outpatient setting that was an elevated potassium. Another thing to notice was this always happened at the annual checkup in January. And again, a month later, when the patient was referred to an internist, the same thing happened. Another potassium was elevated at 6.6 that came back normal when the patient was admitted to the ED, and a blood sample was drawn in the hospital and tested. So what's more puzzling was also that the patient wasn't using any medication, but his sister, who also was admitted a year ago for the same problem, she had a potassium of 7.9 that could not be confirmed in a newly drawn blood sample. So clearly there is something that's happening that's a bit also unique with this family. But typically when, in the laboratory, when we see this, we activate our pseudo-hyperkalemia investigation. So we start asking, what could be causing this? And more commonly, you might be seeing these things with hemolysis, which typically for the labs today, they usually detect those by measuring hemolysis index and stop those results from being released. So hemolysis is really no longer a common reason to get a high potassium result that's released to the patient chart, because most labs detect that and do not release those results. So in this case, it was released. The other thing to note, sometimes during collection, if there's a delay in analysis, that can also happen. But in this case, the sample was collected around 8 and 9 a.m., received in the central lab by noon. So that's not a significant delay for testing potassium. Typically, you'd see that, you may see some slight elevations, but certainly not something that's like 7 to 8 millimoles per liter, which is way above critical. Also, these were collected in lithium heparin tubes that were centrifuged in the lab. So sometimes this can be, you can see some effects if you draw a serum sample versus a plasma sample. So it's helpful to know this. And then the other key factor here is the outside temperatures varied between 34 to 43 degrees Fahrenheit. If you're outside of the US, that's pretty cold, around 2 to 5 degrees Celsius. So it's almost freezing temperature. So pretty cold, and that can indicate a clue there. Something could be happening with transportation. So what is causing this is the part we need to deal with. So looking physiologically at how potassium is maintained in plasma and serum, it's basically thanks to a function of the sodium-potassium pump that continuously pumps sodium outside of the cell against its gradient, and then pumps potassium inside the cell. So you're basically maintaining that homeostasis by pushing potassium against its gradient inside the cell to increase the concentration of potassium inside the cell and increase the concentration of sodium outside the cell. Downstream of that, you have what we call leak channels. So these passively leak sodium and potassium in the opposite direction. So it's a way to keep that balance as well. However, under extreme cold temperatures, the sodium-potassium pump is inactivated. And what that means is that now the leak channel dominates, and you have significant release of potassium outside of the cell and significant input of sodium inside the cell. They go one-to-one. So it is not a problem for most patients who are healthy, where if you leave the sample for a few hours outside in the cold or put it in the refrigerator, that mechanism will not have a significant effect over a couple of hours. However, in some patients with a specific mutation called the ABCB6 gene, that leak channel is modified to an extent where that leak is much more significant. So when the sodium-potassium pump stops working because that sample is experiencing cold conditions, the amount of potassium leak is much, much more significant. And actually, the authors tested this and then recruited healthy volunteers and patients with now what we call familial pseudo-hyperkalemia. That is that condition because it depends on a genetic mutation that can affect the family, like in this case, our patient and his sister. Healthy volunteers over a couple of hours did not experience significant increases in potassium when the sample was exposed to different temperature conditions. You're seeing 20 degrees Celsius all the way down to 6 degrees Celsius. You did not increase more than 20% over 2 hours. However, in patients specifically with this gene mutation, even temperature exposures for, like an hour, you would basically over 50% if you're at cold temperature. So by 2 to 3 hours, you're over 100% increase in potassium. So you're effectively doubling your potassium concentration. So it's very important then for these patients that you don't delay the sample or figure out a way to analyze it or separate it quickly. And also, people don't talk about this, but you also see an equivalent decrease in sodium, which is noted in the second two graphs here in healthy volunteers and these patients. But again, in healthy volunteers, it's not significant. You're seeing these white boxes go down. This designates the decrease in sodium, and the increase in potassium is on the upper end. However, because it's 1-to-1, and because the reference interval for sodium is so large, that the change of 5 millimoles per liter after 2 hours that you may see in these patients is not significant looking at a reference interval of 135 to 145 for sodium. So you're going from a 140 to 135. It's still pretty normal. So you don't really typically look at these investigations or look at these patients and worry so much about pseudo-hypokalemia, hyponatremia. But it does happen, just to point it out. So how can we solve this? What are the recommendations from this case? Really, it's very important that you centrifuge the samples as soon as possible and before transporting them to the central lab. So for all of our clinics that send us samples from the outside, all of them typically spin the samples before they store them outside in the lock boxes and then send them to the lab. And that's important because once you separate the samples, and as long as they're in gel tubes, you're using gel tubes, not non-gel tubes, those samples are stable, even if kept outside, because now the cells are completely separated from the serum and plasma. The other important piece, if you cannot do that, so for some clinics that only send a few samples to the lab, they don't have processors who can spin the samples with centrifuges on site, then what you need to do is to basically make sure that your lock boxes that you're keeping outside, which are not insulated or protected, are moved indoors and kept in a temperature-controlled area, so that as long as you can give access to the courier, of course, basically to be able to retrieve them without having the samples impacted by prolonged exposure to these extreme temperatures. And it is important for me to state that the other factor that could be affected if you're keeping those samples at room temperature is basically glucose may be affected. So you may need to, if you're keeping samples as whole blood, you may need to collect glucose in a different container. The other thing is if you can't do either, point-of-care testing may be the only option. So it's just a third backup if you really can't do one or two above. Fun fact about this is not just a problem for clinical chemistry when we're doing testing, it's also a bigger problem for transfusion medicine, because the familial pseudo-hyperkalemia affects about 1 in 500 patients from European population. And as blood donors, those patients, if their blood is stored in a refrigerated setup for a couple of hours, their potassium goes through the roof, and then you're transfusing those high levels of potassium into neonates or in large levels to other adult patients. They can cause cardiac arrest. So it's very important to be aware if a patient has this condition, and in some cases screening for them before becoming a blood donor. So that was case one. Moving to case two, which is focusing on a pediatric patient with unexplained low carbon dioxide. So in this case, this patient is a 7-month-old girl presented to the ED with a history of diarrhea for the previous 24 hours, but was otherwise well. Blood was collected from the antecubital fossa for electrolyte analysis, so this was like a regular venous draw, and the second sample was collected 2 hours later. The initial blood sample for CO2, again, this is venous, so was 11 when the reference interval was 23 to 30, so it was very low, which was concerning, but it was inconsistent with the clinical picture. So that second sample that they sent, they ran CO2 on that, and that was slightly high. It was 18 millimoles per liter, so closer to normal, but it couldn't explain what's happening clinically with the patient, so they reached out to the lab for an explanation. So the lab, looking at this, went back and retrieved the samples and noticed that the initial samples contained 0.3 milliliters in a 4 ml tube, while the second sample contained 2 mils in a 4 ml container. So why is this important, and why would this happen? So typically, as providers or as nursing staff or phlebotomy staff, you may look at a baby and worry about drawing too much blood, right? So you try to save as much blood from the baby, and you just try to collect as low as you can. Unless you're using pediatric tubes, that can cause issues, as we were seeing in this example. So they basically went and used a 4 ml Vacutainer tube, but only drew a little bit and put them in that tube. So that can cause issues. The other thing is just important to note that delay in analysis can also affect CO2, but in this case, the sample arrived very quickly. It was within 30 minutes on it. So delay was not the big factor here. So what they decided was to investigate this effect on what happens when you underfill the tube significantly versus filling it completely, and how would that affect your CO2 levels. And so what they did was collected blood from different volunteers and monitored that over 240 minutes, and these were their results. Basically, on the bottom end, you have the circle line, the circles filled circles that represent basically a full tube of 4 ml, and you're looking at how much CO2 you're losing over time. So as you go up the graph here, you're losing much more CO2, and as you notice, the trend is the less blood you put in the tube, over time, even in 30 minutes for that 0.3 ml tube, you've lost 30% of over 30% of your CO2. So the moral of the story here is simple. You really need to use pediatric tubes when collecting blood from pediatric patients. If you're using the adult tubes, those can be a problem. And it's important that you fill those blood tubes completely to avoid air exposure in the sample. So for CO2 specifically, that can be a big problem. So it's very important to follow those two recommendations before sending samples to the laboratory. And on the lab side, we really should consider injecting underfilled tubes, less than 50% for specifically CO2 analysis. Also, the tubes should be analyzed within 1 hour following collection. It's more important for CO2 if it's full, it's a completely filled tube, that it's 1 hour from actually uncapping the tube. Because as long as the air exposure is minimal, it will not be an issue, but you don't want to delay too much. And we shouldn't allow, as laboratories, add-on testing for carbon dioxide, which add-on testing means you're basically allowing a physician to add a test on an existing tube, which could have been a couple of hours ago and it's already open for more than a couple of hours. That will not be acceptable for CO2, while we allow it for other tests. So that basically sums up case 2. Moving over to case 3, which focuses on unexplained elevation in lactate. And in this case, we have a 60-year-old Hispanic man who was admitted to general medicine service 2 days earlier with a diabetic foot infection. And his foot was hot, red, and quite swollen, but with a malodorous toe also that was a necrotic nidus of infection. The foot worsened over the next 2 days, and he was rushed to the OR for a toe amputation. And they ordered a lactate 5 hours after surgery, so this was after that was addressed, but the lactate level was significantly elevated. It was 10 millimoles per liter. For reference, the reference interval for lactate is around 0.5 to 2.2, and if your value is greater than 4, that is considered critical. So this was a highly critical result. So the lab notified the resident of this critical result. So this was puzzling because the patient really was receiving antibiotics, fluids, and surgery, but the value was still high. So nothing seemed to address it. And the doctors rushed back to the room to look at, what could be causing this, lack of tissue perfusion. So they suspected, sepsis that could have been caused by the foot infection, but it was not concordant with the clinical picture. They just gave additional fluids and ensured IV antibiotics, and then basically sent more testing. So they did routine labs, blood gases, chest X-ray, and a repeat lactate. While they were waiting for those results to come back, they started thinking of other scenarios. Do amputations cause artifactual lactate elevations? Could propofol from the OR be the culprit? What could be explaining this consistently high lactate level? And then the lactate from the recent analysis came back as 14. So it was even higher than it was before. And moreover, this new CBC, the complete blood count, comprehensive blood count, they basically retrieved for the patient was odd. Patient's leukocytosis has resolved, and the patient now has anemia. So basically, all of a sudden, the patient no longer has a high white cell count, and now that they're anemic. So they started thinking about this new data and suggested that perhaps lactate elevation in back pain could be an atypical presentation of an abdominal catastrophe. So they ordered the CT scan of the abdomen. Meanwhile, Mr. P's niece, who's a phlebotomist, had concerns about the technique that was used by the other phlebotomist and wanted to draw the sample herself. The nurse at that time was intrigued and remembered, could this be caused by LR, which is what they were using, to give the patient fluids, which is lactated ringers. And if you don't know, lactated ringers is a mixture of sodium chloride, sodium lactate, among other things, and it is used for replacing fluids and electrolytes in those who have low blood volume or low blood pressure. So when they basically drew labs from the arm opposing to the one where the IV was attached, the labs were normal. So in this case, the lesson learned from this is that it took days, several unnecessary procedures, and 8 MDs working it up before resolving this error that occurred as a result of improper collection technique. And this is what we call in laboratory field IV contamination. So if you've had could happen with lactate, could happen with saline, could happen with anything that you're attaching as an IV fluid, and then you're drawing a blood sample from that arm or through that same line without appropriately shutting it off and flushing it when needed, can cause these issues. So you'll have really wacky results that don't fit the clinical picture. So what we have here, and what I would recommend for you at your own institution, is to make sure you have policies to detect these first of all, and also to have recommendations to the teams of what to do when you see them, and what have best practice for making sure that you are collecting enough dead space volume. Usually we say you have to basically collect a discard tube at least before collecting the sample you sent to the lab. And then we also say you should, if you can't get a reliable result from the IV, just avoid using the IV to draw the blood sample. Go to the opposite arm of the IV site. If you can't draw below the IV site, and if unable to do that, then at least shut off the IV, wait 2 minutes, collect the discard tube, then send the sample. And we have ways of detecting these in the lab and how we flag them for our clinical teams using delta checks. So we recently published a paper that basically developed new rules to better detect these, so we can flag them at a better rate. And that covers case 3. So we're flying through these, which is great. We still have 3 more cases before we wrap up and talk about any other questions you like. But case 4 focuses on discordant point of care results and main lab glucose results. So in this case, we have a patient who's a 63-year-old man with metastatic lung cancer who was admitted for severe hip pain and malaise with no other symptoms reported. The patient had erratic daily morning plasma glucose concentrations with several critical values that are less than 40. So for reference, the reference interval for glucose is usually 70 to 100. So these were kind of significantly concerning, like very, very low critical glucose. However, every time they had a low critical glucose from the main lab, they would draw a finger stick glucose and measure it using point of care by the patient's bedside, and that result comes back normal. So you have a discordant result between what the main lab is saying from the hospital, and then what basically the finger stick is saying collected bedside and ran by the patient. So which value is correct here? Do you trust the finger stick or do you trust the plasma glucose, and why? So the recommendation is to always focus on the clinical picture. In this case, the patient had no symptoms of hypoglycemia, which for somebody with less than 40, that would be pretty obvious. So that indicates that the plasma glucose is likely falsely low. So what can cause a falsely low plasma glucose? There are 3 common causes. One is delayed separation from cells. So glucose typically degrades at a rate of 10% per hour. So if the sample is kept as whole blood, and if you took a long time to get it to the lab to be ran, that can basically, your glucose values will be falsely low. Now, in this case, we know that did not happen. The sample was actually delivered to the lab within 15 minutes. So it wasn't a delay or in terms of separating the cells and running it. So leukocytosis is another big one. So if you have a lot of white cells in that blood sample, white cells, just like red cells, also consume glucose. So except instead of your average 10% per hour decrease, you could have over 100% decrease per hour in terms of glucose degradation. So much, much faster, because you simply have more cells eating glucose or consuming glucose that's present in the sample. Or hypoperfusion can be another issue that can cause these typical low results in that specific area. However, when we tested the patient's white cell count to rule out leukocytosis, we found that they had over 30,000 cells per microliter. So that definitely is the cause. And it's a common phenomenon in patients with non-small cell lung cancer. So especially in patients with cancer, if you have a cancer clinic where you draw blood samples, it's extremely important to be vigilant about this and to make sure that either the sample is run right away, or that you're basically, your only option might be point of care testing if you can't stabilize it. And so in this case, it's extremely high white cell count that consume glucose much more rapidly, and even a 15-minute delay in the sample will not allow you to run it appropriately. So what can you do? And one of the other suggestions is running the sample, but using a sodium fluoride tube, which is a gray top tube, to collect it and send it to the lab. So gray top tubes stabilize glucose by stopping the glycolytic pathway. So what happens if you collect it in a gray top tube versus your lithium heparin or serum is you stop consuming glucose. You have slight degradation, but then it stops it. So you can run that sample even several hours later and get a normal result. So, and that's in this case what really resolved this. So what are the recommendations for when dealing with situations like this one? A, immediately measure whole blood glucose samples or separate them from the cells when not possible. So this is also important for those, if you work in a clinic and you're sending samples to the main lab,
really having a centrifuge and a person who processes those samples in your clinic was vital for the quality of your results. So if you cannot achieve that, then really the only other option, you'd have to basically collect blood in a separate tube for just glucose measurement, which is the gray top tube. Unfortunately, we cannot measure the other tests that we run on a comprehensive metabolic panel or basic metabolic panel on the gray top. So that means you're going to have to send 2 samples for every patient you're trying to get this measured on. One would be for the rest of the chemistry tests, and one would be for glucose if you do not have a processor. And finally, in patients with extremely high white cell counts, like some cancer patients, rapid analysis by point-of-care devices may be preferred, or your only option may be sending them, again, gray top tubes as well would work for this, as we've already shown. So now moving to cases 5 and 6, which are slightly different in that these are not patient-focused, these are problem-focused. And I use this as an example because these are things that we on the laboratory side often get as feedback when there's a problem with a certain test that we're doing that our clinical partners are seeing. They can reach out to us and say, hey, we're seeing this issue or this problem, and we typically investigate and try to address it. In this example, we've received complaints of too many high calcium results. So I don't know if you get that on the laboratory side or on the clinical side. Do you notice this with some of your patients or a lot of your patients? All that matters. So the story here is that as a laboratory director, received a complaint from a group of physicians who recently joined the health system, and they were concerned that they were seeing too many abnormal high calcium results. The director requested data on the percentage of high abnormal calcium results by location so they can investigate this further. So typically here, it's a good idea to try to look at data that help understand the problem. And so in this case, given that some clinics were seeing this, we thought it would be a good idea to basically look at how much are they seeing, and is that a problem, and is it different from other sites? Because again, these are a group of physicians who recently joined. So this is the data analyst then provided this data for the health system, but excluded sites with less than 60 collections per month. So we're only focusing on the percent of high calciums for each clinic, but only for clinics that have drawn enough volume of these samples. So in this case, you're seeing these are 4 clinics listed here that met those criteria, over 300 draws per month. And then the percentage of high results you're seeing in all of these outpatient clinics is around 15 to 16 or 17%. So the question that would come up first, is this a problem? And thinking through this and knowing in laboratory medicine, typically when we derive our reference intervals for our patients, it is based on excluding 5% of healthy individuals, meaning 2.5% on the high end and 2.5% on the low end. Should flag as high based on the normal way we derive reference intervals. So we stay sensitive to diseases and can kind of monitor things more closely. So in this case, in an outpatient setting where you don't typically expect, because again, most of these are part of CMPs, so they're not specifically being evaluated for hypercalcemia. These are outpatients. So a 16.8% is extremely high as a flag versus what I would expect is somewhere around 3 to 5% max. So yes, definitely this indicates that there is some issue that is happening. And then looking specifically at the clinic locations, I know the names probably don't mean much to you, but the PED stands for pediatric locations. So 3 out of 4 locations are pediatric locations. And the 4th one also collects pediatric samples, but it's not just a pediatric location. So what is happening here, and is that a clue to something? So the site was using a single reference interval that was designed for adults. In the example here, that's 8.8 to 10.2 as provided by the manufacturer. I will say, for providers who are surprised by this, most manufacturers do not provide you pediatric reference intervals for all their assay. So some laboratories, they have no option and simply validate the adult and only list that. Others may try to derive literature-based reference intervals and then verify them if they can. Although simply that may be impractical, and they might just decide to plug them in for that specific assay if available. But it is not uncommon that many labs do not yet use pediatric reference intervals because it's simply not provided for that assay. But it is important to say, recently there's been a lot of studies that have come out. Specifically, I cite the one here, which is from Canada, that have recruited over 10,000 healthy children to derive reference intervals for major manufacturers like Roche, who we use here, and basically have published all their data. And we can basically choose to use that and verify if possible, and if not, most labs are trying to implement these and trying to figure out ways to verify. But in this case, what they've shown is that for 1 to 17 years old, that reference interval is 9.3 to 10.6, and less than 1 year old, it goes even slightly higher to 11 on the high end. So you have patients, pediatric patients, who are between 10.2 and 10.6 at least, and 11 on the less than 1 year olds, whose result is actually normal for their age group, but would be flagging high if your laboratory simply implemented the adult ranges only. So this is very important then to state that you need to basically try to implement pediatric ranges where you are if you don't. So if you're a provider interpreting results for pediatric patients, be extra careful and double check that the reference interval applied is not simply an adult range. And you may find that out by just simply contacting your lab director or your lab provider to understand what they're doing and how they're doing it. And as I mentioned already, assay manufacturers may not provide that. So if you're a laboratory director struggling with that decision, I would say you should consult caliper studies, which are the best literature that we have now. There is a big push in the United States to try to do these studies as well in the US, but so far Congress has not approved spending for these. And there are a number of associations like AACC, the one I'm part of, that's actually actively pushing Congress every year to fund the CDC to allow us to basically do these pediatric studies so we have more reliable reference intervals for our population. So far, this has not happened. And so the one I would recommend using for now, if you haven't heard of it, it's called Caliper. And that's basically the most reliable to date. And it was published in the last decade. So a lot of this is new. And I wouldn't be surprised if your laboratory is not using them already, but many are, and they're moving in that direction. So I would highly encourage you to consult Caliper in order to implement pediatric reference intervals at your institution. And so we're great on time, and now we can dedicate the rest of the time focusing on everybody's favorite topic, which is hemolysis. And I saved this for last specifically because it is a big one. I will say it will take usually more than one lecture to just focus on all the things that will cause hemolysis. But the number one thing I will state, no, your lab is not hemolyzing your samples. Hemolysis can happen for a variety of reasons that could include poorer collection techniques and poor transportation techniques. But there are some things that the lab can do to help reduce the effects also that, when they're reporting results to you. But predominantly, we need to work together to address these issues. And so I want to focus on two problems at once here. So adult emergency medicine and the neonatal intensive care unit. So we have something for adult ED and the neonates in the NICU who are complaining of high rates of hemolysis. And for those of you who are not familiar, which I doubt since the majority of you are laboratory professionals, hemolysis looks like what we are seeing in the picture below. When we separate the blood sample by spinning it down, you see, you should see the plasma look like the sample labeled number 1. As you have more hemolysis in the sample, you start having basically more cells are lysing, and you're releasing more hemoglobin into the sample, along with a lot of other things that can interfere with testing. And so you see it gets slightly more orange, slightly more red, and then finally, you have severe hemolysis, which you see here with red. And so how do we stop this? It's important to say, for the ED, there's different analytes that are predominantly affected than for the NICU. For the ED, you typically see severe elevations in potassium, and we're actually not giving you that result, so all you get is essentially sample hemolyzed, and then you'd have to redraw the sample. Same, troponin high sensitivity assays are more susceptible to that level of interference, so that can be a problem for the ED, and they're always contacting us about these two analytes specifically. For the NICU, the one that is more commonly affected is direct bilirubin. So I don't know if you could relate on your side as a provider or as a laboratorian if those are the most common ones, but basically it's important to say that hemolysis does affect things differently and at different levels. So if you are getting a result for maybe AST or sodium on the same sample, you might not get potassium simply because it's so much more sensitive. And the most sensitive analyte that we have is actually LDH, so lactate dehydrogenase, but it's not as commonly measured, so it's not quite as much of a problem as we see with potassium. That's more commonly needed. And again, as I've already summarized, the problem is not your lab. It's basically a combination of collection technique and transportation. So what can go wrong and how can we address it in both areas? But before we go there, I do want to say again, there are some things, as I mentioned, that your lab can do to help with these thresholds. So first of all, manufacturers typically assess the effective interference only using one concentration and a 10% change for all analytes, which is not necessarily best practice. A 10% change for sodium means one thing versus a 10% change for potassium or glucose. So 10% in sodium is going from 140 to 126. That's not acceptable. Your thresholds for sodium should be much tighter, whereas your thresholds for potassium can be looser because going from a 3 to a 3.3 is not that significantly different, clinically at least. So it's important to remember that those thresholds that we're getting from manufacturers may not be the best for clinical care. So we need to reevaluate these as directors and make sure that at least for those sensitive analytes, they are appropriate. And so for those that are sensitive, what you can do, and what I recommend, is reevaluating and establishing it at different concentrations and using tiered thresholds. Now, what does that mean and what does that look like? So this is an example for high sensitivity troponin that was published from the Mayo Clinic, where they basically, instead of using one cutoff of hemolysis that the manufacturer gives, which is a hemolysis index of 100, so if you any values that are greater, hemolysis index greater than 100, which is what we use in the lab to tell if that sample is affected, would have been rejected. In this case, by splitting it up and focusing on areas, lower concentrations, you have, if it's less than 8, it would be 300. If it's 9 to 37, it would be 195. So it varies based on the concentration. Because let's face it, you may care if troponin is 10 versus 15. But if it's 350 versus 330, is that really a big change? Because right now, you might be rejecting them, whereas clinically, that is important for the clinician to know because you're not giving them any results when knowing that it's that high alone is very useful for them. So I strongly recommend following this approach for those sensitive analytes and establishing criteria for change, which in this case they used like delta of 2 for the low end, less than 8, and a delta of 4 for the high end, making sure that's appropriate, and then establishing new thresholds that change by concentration. We use these thresholds in our lab. The other example for direct bilirubin as well, there's another study that was presented by the University of Iowa researchers who basically did the same thing with direct bilirubin and split them up, by concentration. So just so you know, for direct bili, manufacturer recommends any change over an H index of 30, which is very low for hemolysis, should be basically rejected because it causes a significant change. But what the researchers have shown here, really, you can be more tolerant using more reasonable criteria and by splitting that up based on concentration. So in their case, they would be reporting up to 140 for anything less than 0.5, which would be hopefully the majority of patients. And then they would put a disclaimer on the results if the results are between 140 and 200, saying there may be a change up to 10%. So you as a provider know that this result may be slightly affected by hemolysis. And then if it's hemolysis over 200, they're canceling. So that we won't give you that result because we know it's significantly affected and it's not going to be useful for you. So this approach, which I like to call the traffic light approach, where if it's no interference, green, release the results, but you've used reasonable thresholds to decide what's green. And then if there is some interference, slight level up to 10%, let's say, you can say, okay, release the result with a comment. So in case they're questioning it clinically, they recognize there might be some interference. And then red, significant interference, do not release the result at all. That approach really helps you not reject too many samples and actually still give results that may be clinically meaningful for the provider to have. So that's the approach that we follow here. And I highly recommend on the laboratory side, at least to make sure you're using these to flag samples if they need to be flagged with a comment, or flat out reject them if they're too high, instead of one threshold to simply reject. So we've talked about what the lab can do. Now let's focus on the issues that can happen in transportation. And then we'll get to collection quickly for any providers or phlebotomy teams or nursing teams who collect blood, so they kind of get a sense of what needs to happen there. So for transportation, we recognize that for the NICU specifically, it does have some effect for adult patients as well coming from the ED, but your pneumatic tube system can be a major source of hemolysis. And that's simply because you're loading the samples in these carriers that are traveling at high G-forces to the laboratory. So the longer they're going through that system, and the more turns and twists, you can have significantly more hemolysis. So if your ED is located very close to the lab, you may not have as many issues. But if you're further away, or the location that you're sending samples from is further away, you will have issues. So for the NICU, what we found helpful here for us is by padding the tubes, as you see in this picture with foam inserts, those specific samples coming from the NICU are basically protected throughout transportation. So by implementing this and using yellow carriers specifically to designate these as NICU carriers, and they have these foam inserts on them, we were able to significantly reduce the effects of hemolysis coming from that clinic. However, the foam inserts, were not a successful initiative on the adult ED side, simply because they send too many tubes to only fit like this wide foam inserts, and so this would not work because you increase your traffic significantly if they're going to send each tube in a carrier. So for the NICU, it works because you don't get that much volume, but for the ED, it would be next to impossible to use this. So sometimes, if you're having repeated problems for some patients, your only option may be to try to avoid using the pneumatic tube system to get your best chance at getting a result for that patient. So you may often hear the lab asking you, please walk the sample to the laboratory to get a result for that patient if you keep repeatedly having issues. It simply doesn't mean that this is affecting all patients, but it just gives you the best chance of getting a result, because again, hemolysis is cumulative. So trying to reduce the effects of transportation so that you kind of make up for that difference and may be able to get a result. So now, in the last few minutes, I'll just say collection is a whole world of things that can happen. So I just tried to focus on 2 practical recommendations that I can ask you as somebody who's collecting blood samples should be aware of. One is a study that came out of Cleveland Clinic, who is basically evaluated the effect of using smaller tubes. So they went from 6 milliliter tubes for collecting blood for the ED to 2 milliliter tubes. And what they noticed in that period, what I'm showing you here, is that hemolysis rate on the beginning in 2013 was around 14%. And that shows you the baseline. But then when they tested using the smaller tubes, that dropped to around 2 to 3%. And then they basically went, that was considered a successful pilot, but then they needed to get, obviously, supply chain on board and then implemented. So you see a post-test period that went back up when they went back up to the regular size tubes, and then that dropped significantly when they finally implemented the use of these smaller tubes. So even for adults, using smaller tubes can be significantly helpful to reduce the effects of hemolysis. And that happens, we think, because of 2 mechanisms. One is using the smaller tube means that you're basically drawing less blood, so there's less to travel in the tube. But also the main reason is because the larger tubes have higher vacuum in them. Those vacuotainers contain a higher amount of vacuum. And with higher vacuum, you're pulling the cells through the needle much faster. They're still going through that faster rate. They could be shearing the cells as they're getting in the larger tubes. So using those smaller tubes, there's less vacuum, therefore less force on the cells as they're drawn into the tube and being collected. So the recommendation here is definitely switch to a smaller tube size if you can, as long as you know that's also compatible with your automation line. So the one thing to check is make sure that your laboratory can handle that switch, and those samples can be run on your automation line. The other key factor here is also, this is unpublished data from our lab being done by our postdoc, Dr. Hemolysis, who basically looked at fill volume and the effect that has on the tube. Now, we've already talked about fill volume for carbon dioxide. Same thing happens actually with hemolysis. If you're collecting less blood in a larger tube and you're not filling it all the way, as this data suggests, low means less than 25% blood in the tube versus partial is between 25 to 75, and full is what is over 75% of the tube is full. You have less hemolysis when you're collecting full tubes. The reason we think that happens is, as already mentioned, the beginning part of the tube is where the highest vacuum is. So the first portion of the blood that you collect will experience the maximum amount of hemolysis. And as you continue to collect, the vacuum is dropping because it's filling. So what then happens is there's less and less and less force over time. So then if it's sort of like brewing coffee, where if you pull that coffee pot too early, when you've only gotten the first part filled, that's the most concentrated part. And that's why that tastes very dark and bitter, right? So they tell, like, leave it till the end because that's when it dilutes. The same principle applies here. If you're underfilling a tube, you're basically having the highest amount of hemolysis. You need to fill it completely to dilute that out so you're able to get a more reliable result in the sample. So the main message here for hemolysis then is essentially try using smaller tubes and make sure those are filled completely. And I will not go into, there's plenty of more things that can cause it, but I'm just going to keep it practical for now and at least ensure that those are two simple, hopefully, changes you can implement that would help your hemolysis. So these are the full recommendations for the other things that I also haven't talked about for hemolysis. Essentially, we talked about transitioning to smaller size tubes, and we said you must fill them all the way. I would also recommend using vacutainers instead of syringes to draw blood. I know this is practice where they basically draw blood through syringes and then put them in a vacutainer tube. That is bad simply because blood is flowing through that needle twice, once in the syringe and once back out into the vacutainer. You have more chance of hemolysis when you do that, and that draw from a syringe also depends on the operator. Go too fast and too hard, and you're gonna hemolyze the sample. So you really need to be careful if that's the only option you're doing and to draw slowly. But if you can avoid it altogether, do not do it. Also avoid drawing blood through IV lines. A straight stick is preferred, so not using that. And collect serum instead of plasma and walk to the sample to the lab if hemolysis should continue to persist. So with that, I get to the final slide, which is my summary. Going back over everything we've learned today and the points I want you to leave with. For case 1 for potassium, centrifuge samples quickly and make sure lock boxes are in a temperature-controlled environment. For bicarbonate, use pediatric tubes when needed and ensure that the samples are filled all the way and ran within the hour. For lactate or other issues that could happen that could cause IV contamination with other analytes as well, avoid drawing samples from the IV line or ensure appropriate flushing prior to collection. Implement delta checks in the lab. For glucose, process samples immediately or use fluoride tubes. For calcium, implement pediatric reference intervals for all assays. And hemolysis, implement tiered thresholds in the lab. Protect during transport, collect blood in smaller tubes but fill them completely, and avoid using syringes or drawing from an IV. Walk the sample to the lab if necessary to avoid those transportation issues that can happen with the pneumatic tube system. And that's basically my talk. Again, there's plenty of more of this content that will be available on my YouTube channel. I would encourage you to check that out if that's of interest. And with that, I also would like to get a sense of how useful did you think this was. As we transition to the Q&A, feel free to answer this and give me if more feedback also will be available through the survey that will be provided at the end for comments. Thank you for your time, and I'm happy to take any questions at this stage.
Thank you, Joe, for your informative presentation. So we got that poll up, and we will now start the live Q&A portion of the webinar. So if you have any questions you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many of your questions as we have time for. All right, so let's get started. So one of the first questions I see is, we have a lot of questions coming in, that's awesome. So this one says, the majority of sera are stored in a freezer. This means results could be questionable if the values are high, and this means the test could be immediate without exposure to low temperature. Do you have any comment on that?
Absolutely. So that is an excellent question. Basically, majority of samples are stored, and to clarify, in a refrigerator, at least for clinical use, not freezer. And usually we store them ideally after separation from cells. Right? So when you've spun the sample down and there's a gel separating the plasma from the cells, that sample is protected and potassium will not change even if that sample is stored in a refrigerator. The problem exists if the sample is stored as whole blood. So if you take a sample that's whole blood and you store it in a refrigerator, and I want to be clear, longer than 3 hours, you will have issues with potassium. It will slightly start to increase. But then in some of those patients that I mentioned specifically today, familial pseudo-hyperkalemia, even 1 hour of whole blood storage refrigerated is a problem. So yes, it is not ideal, but you won't recognize it except for those specific patients if you're storing it as whole blood, as long as you don't store it more than 2 hours. So in a nutshell, most samples clinically are stored refrigerated after separation from cells. If you are keeping them as whole blood, you don't want to keep them that way for more than 2 hours.
Awesome, thank you so much. The next question I have here says, great talk. Why would a serum sample be better for LDH, than plasma?
Yep. No, excellent question. So that typically we think is related to primarily transportation. So serum, what we found is for any hemolyzed sample. So I just want to start by saying we are a primarily plasma lab as well. So we send lithium heparin from the ED. However, when we see these issues with hemolysis, we sometimes recommend that they collect a serum sample instead and walk it to the lab. And the reason why we think serum can be more protective from hemolysis is because of when you coagulate serum, that clot that forms, the clotting process, can be protective, because what happens with the clot is it holds all the cells in place, we think, and then when you spin down, essentially it removes all of the cells, and then you can run it. But throughout that time when they're held by the clot, they're not lysing as much versus a plasma sample that could be. And we actually just published a paper on that, showing that a serum tube is more protective during transportation by a pneumatic tube system, but it has to be fully clotted before being transported. So for that purpose, we used rapid serum tube, which is the orange top tubes, and show that basically if you send those alongside a plasma sample, the orange top tube is protective, and it has lower levels of hemolysis. We think it's purely mechanical, where basically they're protected by the clot during transportation. But again, it's still it's still an area that we're studying. We think that it wouldn't be helpful if the primary issues you're seeing are with collection. And I need to be clear about that. So if you don't have any issues with the pneumatic tube system and transportation, a serum tube may not significantly help.
Awesome, thank you. And the next question that I see come up is, how would you expect hemolysis to impact the co-oximetry measurements? Not sure if I pronounced that right.
Yeah, so for co-oximetry specifically. So I have not come across that because I don't oversee blood gas testing here. So I would have to pass on this one. I apologize, but it's not something I would see here, and I wouldn't know the answer to that question.
Okay, thank you. And the next one I have, what are some tips for dealing with lipemic turbid samples, and how do you use lipemic index, and which instrument manufacturer lipemic index do you use?
So we're primarily a Roche customer here for our main testing. So we use their L index and their thresholds. And for lipemia, it's typically more straightforward for us because we simply ultrafuge the sample. So we use an ultracentrifuge to spin down the lipid layer and basically take the fraction that's then now remaining the plasma and serum and then run that. So we don't have any issues with lipemic samples because we ultracentrifuge them.
Great, thank you. The next one I have, what is your hemolysis rate for newborn babies? What is the average H index for hemolyzed sample in newborns?
So that is an excellent question. So before we basically implemented the change that we did, we were seeing as high as 12% of the samples were rejected in the NICU. Once we implemented the change where we basically used the foam insert, that dropped down to around 3%. That's for total rejection. So sometimes you may be flagging samples still based and commenting and like releasing a result, but at least total rejection significantly dropped. And there are published literature. I think Mayo Clinic also did a study where they did evaluate those effects in the NICU, and they show like something around 3 to 4% is normal in the NICU.
Okay, the next one I'm seeing, does a syringe for collection have an effect on the hemolysis?
Absolutely. So that can have an effect. So the recommendation here is to use usually around 18 to 20 gauge size needles for collecting blood. Although sometimes we recognize in some of those difficult sticks, like cancer patients, you may have to use a smaller bore size, which can cause issues. But yes, definitely that has been documented to have an effect.
Okay, and then the next one I see here, not in the form of a question, but of note, potassium result in serum is higher than in plasma. Do you have a comment on that?
Yes, so that is correct. I mean, we know that in most patients, serum is about 0.3 millimoles per liter higher than in plasma. However, your reference intervals should reflect that if you're using serum as well. So in some places, they use different reference intervals if you're collecting serum versus collecting plasma for that reason. Others just use a combined range. But again, the differences we're trying to solve here, a 0.3 change is not clinically significant. This only matters if you have patients with significantly high platelet counts. So patients with thrombocytopenia, you cannot, or thrombocytosis, sorry, you cannot collect serum samples for those patients because their potassium would be through the roof. So yes, in some, it's a very difficult analyte to deal with. In some cases, plasma is better, like in patients with thrombocytosis. But in the rest, serum sometimes may be better if you're seeing hemolysis issues, even though that it may be 0.3 higher. 0.3 is not a clinically significant change.
Great, thank you. Next one, do you have any recommendations with regards to transporting urine specimens to an ulterior site where it will not be analyzed before at least 3 hours, inter-hospital transport?
So urine stability for each analyte can differ depending on the additives that you include. So it really depends on what you're testing and how long you're collecting it before sending it to the lab. Some labs do like urine acidification when they receive them. It really depends on the analyte. One recommendation I have, if you want to check what is best for stability by different analytes, I really recommend you go to Mayo Clinic's website. They have, and look specifically under urine stability, they have a whole table in a nice PDF file for every analyte, the different additives that make them stable. So you just have to make sure that you're collecting in the right, in the jug with the right additive so that it makes it stable for the longest period of time possible. But that will vary by analyte.
Okay, great, thank you. Next one, in the case where electrolytes are requested every 4 hours, is it advisable to take from a central line to minimize pain, or peripheral blood sample will be best?
And again, that's the common issue, right? That's why people commonly collect from IV lines to try to avoid sticking the patient every time again. It can be safe to do that if you've done appropriately. Certainly, if you're basically shutting off the IV, you're waiting a couple of minutes if you need to, and then discard a tube, then send the tube to the lab, and you don't see any issues that look abnormal, then it shows that it's okay. So you can try to do that, but when you have issues, that's what I want to get to. When you start seeing these results that are inconsistent with the clinical picture, because what you typically see could be a dilution of all analytes not associated with the IV, and an increase or a normal concentration for the analytes that are being infused. So if you see that, it is important to basically verify it by taking another sample from the opposite arm, or just to make sure that it's not, before you take any action on it, so it's not a lab artifact.
Thank you. The next one I have, does drawing patients with butterflies or straight needles have a higher risk of hemolysis?
So that's an excellent question. So with collection, again, we've seen some conflicting reports, but more people are recommending straight needles. I have not seen that at our location. I will say it is something that really depends on a lot of techniques. So more people recommend straight sticks, but also recognize it's impractical, and the effect that's coming from that may be minimal, meaning that in the big scheme of things, butterfly versus a stick, as long as you're not using very long lines in between, again, these can increase that because of the travel. I would say like you're likely okay. So these, based on the studies I've seen, at least, these are not major contributors. Straight stick does look slightly better.
Thank you so much. We have time for about 1 or 2 more questions. Next one I have, do you ultracentrifuge all samples or only lipemic samples? And at what level of lipemia do you use ultracentrifuge? And then it says ultracentrifuge does not help with the turbidity caused by lipid or lipoprotein factors other than high triglycerides. The lipemic index correlates poorly with triglyceride levels.
All correct. So to begin, do we ultrafuse all samples? No, we don't. We only ultrafuse samples that trigger the lipemic index for every specific analyte. So for example, direct bilirubin has a lipemic index of 100. Sodium has a lipemic index of 700. So if a sample is trying to get direct bilirubin, if it's above 100, we're going to ultrafuge it. If it's above 700, then we can also ultrafuge it for sodium. So it depends on every analyte, and we have a clear table with these guidelines. To answer that, the other piece of the question was regarding the correlation with triglycerides and how it wouldn't resolve anything other than high triglycerides. I agree. However, that is still a generally useful metric for detecting those samples that can deviate significantly. I can tell you from our lab, we even see issues where an L index is falsely high because of other components that interfere with L index, like biliverdin. So we've seen in some patients who you take the sample, the L index is let's say around 250, then you ultrafuge and that L index doesn't change. It's still 250. That is usually a sign that you have pseudo-lipemia. And for those samples, we've recently reported a case where you basically can release the results because it's not really a lipemic interference. The sample color is usually green, and that is the wavelength that the lipemia index is checked on. So those are other factors that could affect it. But yes, certainly it's not a perfect marker, but it's the best we have to try to spot those samples that we have issues with. And yes, anything exceeding that threshold, we would ultrafuge.
Awesome, thank you. We have time for one more question. How would hemolysis be expected to affect co-oximetry measurements?
I think that already came up, and I addressed it. Let's see.
Did it? Okay. We can move on to another one. This one says, why would it... Go ahead.
I see the one on calcium. I think they're saying like 5% is in a normal population, but in a hospital, people are 16% is okay. Yes, so to clarify, these are from outpatient centers. So they're not, these patients that I mentioned for calcium, 16%, these are patients who are not in the hospital. They're being checked maybe for other reasons. They're sending a comprehensive metabolic panel that includes calcium, or a basic metabolic panel for us also includes calcium. So 16% in a hospital may be a problem, which is why I wouldn't have worried about it if it was these patients were in the hospital. But outside of the hospital, that is huge, and that was directly linked to these pediatric patients that I mentioned.
Okay, thank you so much. And thank you to our audience for those questions. And thank you for your time today and your important research. We would also like to thank LabRoots and our sponsor, Radiometer, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and their interesting questions. Questions we did not have time for today, or those submitted during the on-demand period, will be addressed by the speaker via the contact information you provided at the time of registration. And this webcast can also be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, thank you so much, everybody. Bye-bye.
Thank you.